I am so happy to have you both here today to talk about this specific topic of chromosomal abnormalities within infertility. And I know each of you have different experiences within infertility, both personal and obviously professional. Um, but first, before getting like too heavy and into things, let's just take a second to introduce yourselves and maybe just share a little bit how your experience with infertility has been and your expertise on it.
I'm Chriselle Lim. Super happy to be here with both of you, old friend Whitney, new friends. Most of you guys might know me as being a OG content creator. I'm also the founder of Fleur and Boomo. And I've had a number of stories, mainly miscarriages. I've had multiple miscarriages. I think I've had a total of 3. And it's something that I commonly just openly talk about because I know a lot of women go through that. And I have within my family, my sister who also struggled with infertility that did IVF. So yeah, I'm super passionate about this topic.
Yeah.
My name is Dr. Mandy Katz-Jaffe. I'm the Scientific and Genetics Director at CCRM Fertility. I'm an Aussie, born, bred, and educated, and very proudly a reproductive geneticist. And I have worked in the field for a couple of decades now.
We've talked a lot about different areas of infertility, and in that it's been so therapeutic for me because I've been able to also share my story within that. And I'm like live going through something at the moment. It's just so interesting because then to be able to talk to an expert when I'm dealing with something at the moment, like I have just so many questions. But everybody knows here that we have, I've experienced like infertility, not to the max by any degree, but it's hard for me to even talk about, but 5 miscarriages, and decided to go the route of surrogacy at the end of last year after just like mentally and physically breaking down and realizing that it was just best for my family not to carry the baby myself. So we luckily found an amazing surrogate very quick. That process was amazing, and I feel very privileged to have done that. But long story short, we have done 2 transfers with our surrogate, and she's miscarried both times. She just miscarried at 8 weeks 2 weeks ago. And it's such a hard thing because we have 5 embryos, and they're all graded and tested, genetically tested, and we've been given the sex of them. And 2 of them were boys and 2 of them were girls, and 1 actually not tested because it wasn't weak enough. And so we put the girl in both of the girls in first because we already have a boy, and I really wanted a girl. I wanted to try, and both those girls didn't work, but they were graded lower grades than the other 2 boys that we have. The 2 boys got to where they needed to be quicker than the 2 girls. So there's now all this thought in my head of like, should I not have known the grading? Should I just have put the strongest one in, which is what my husband wanted to know? The chromosomal abnormalities that can happen even though they are genetically tested. Just because it's genetically tested doesn't mean it's still like a completely viable embryo. So many questions, but just to give you a little bit of context of like where I'm at in the process right now. So it can guide our conversation, but totally open to talk about it because I know that the more that we talk about this, the more people can feel comfortable living in their own version of what their normal is, and know that places like CCRM are here for them. So first question for you.
Sorry.
Yeah, thank you. Sorry to like just spring all of that on you.
I mean, I think it's before we go into the first question. I think that it's people like you who really make people feel less alone because I don't think when you're going through that you realize how common it is.
Mm-hmm.
And that was my case. I was one of the first creators to be pregnant about 12 years ago. And so no one around me really, I didn't have any information of like people having any miscarriages. So I thought there's something wrong with me or I did something wrong to my body. And so I punished myself for a very long time. And so I think it is people like you speaking up about these hard times to really just like normalize it, and the person that's going through it feel like there's nothing wrong with them.
Right. Like there's nothing that we did wrong.
Yeah.
Like there's nothing that we have control over. And that's one of the hardest parts of this whole thing is the lack of control.
I
that we
remember
have.
just being so stuck on one thing because I ran a full marathon like without knowing I was pregnant. And I just kept blaming that. But then, of course, it happened 2 times again later with different pregnancies. And I'm like, okay, it obviously wasn't linked to just that. So I think we do that to ourselves.
Of course.
We like think about what we did or what we could have done. But yeah, I'm so glad to have you here to kind of talk about more of the scientific and the reason behind everything, because it's hard.
Yeah, because do most miscarriages result from chromosomal abnormalities?
Yeah, about 70%. In some publications, a little less, some a little more, but absolutely. And this is spontaneous pregnancies, right? That result in loss. About 70% are chromosome abnormalities.
Right. And then the eggs are... like the embryos are less chromosomally viable the older the woman gets, correct?
Yeah. So unfortunately, we're born with all our eggs.
Yeah.
And that's all we get in our ovaries. And they're tiny little eggs. And then, of course, we go through puberty and menstrual cycle, and these little eggs then they develop and mature. And that happens right throughout our lifetime up until menopause, when we don't have many more eggs left. But those eggs that were born, they age with us, or they age with our ovaries.
Right.
And so that's what is the driver of these chromosome abnormalities, which is losses and gains of chromosomes.
Okay.
They're old eggs.
Right. So the saying of, the old age saying of like, it gets harder when you're older is true. Then.
Absolutely.
Okay.
Absolutely it is. But don't get it wrong, right? Actually, younger women also have eggs with the chromosome abnormalities. They just have less of them.
Right.
So therefore, you're less likely to see them obviously present in a clinical pregnancy because there were less to start with.
Right.
And so as we age, we lose eggs, and then the ones that are left are older and poorer quality. And so therefore, there's more of them that are poorer quality and have chromosome abnormalities. And therefore, that leads to that increase in the chance of having a pregnancy with a chromosomally abnormal egg, and therefore a loss.
Right.
Yeah.
When you miscarried, did you have to get a D&C after, or did you just like bleed it out, or was there any option to do an autopsy on the embryo? Yeah.
So the first miscarriage, I had 2 miscarriages before I had my first daughter, Chloe. The first one, it was early on, so I was able to it just kind of passed, right? The second one, I did have to get the autopsy and all that because it was a little later on. And then the third one, which happened before Colette, it's almost like a pattern. It's almost like you have to go through a certain amount of miscarriage, at least for me, before becoming pregnant, like fully pregnant again.
It was like your body was doing something to like clean itself out or something.
But is that the process?
No, it's not.
No, I mean, I'm so sorry that you went through, both of you, and you're both incredible that you're talking about it, going back to, being able to normalize it, right? Instead of women actually suffering in silence.
Yeah.
So sorry that you've both experienced multiple miscarriages. Not everyone does, obviously, but normalizing it for the women that do is so incredibly important. And we're an aging reproductive society.
Totally. That's one thing I've learned.
Therefore,
we're all getting pregnant so much later, or wanting to get pregnant so much later, or trying, of course.
And the increase, that results in an increase in the potential to miscarry. So we're going to see it more and more. And we know that with our aging reproductive society. But when you had the D&C, was it actually, did it get sent off for genetic testing?
Yeah, it did. And I don't know if it's linked, but is it also linked with family genetics by any chance?
So a smaller proportion can, but that's more rare than just having a chromosome abnormality that's a chromosome that's either lost or in addition And in a pregnancy loss, we typically would see an extra chromosome being present.
Got it. Because my sister also, she's giving birth next month, but she went through the IVF process, and she also went through the same process as I did. So I was like, wait, is this genetics? Like, does it have to do anything with kind of our, I don't know, our makeup and our body?
But I would doubt it based on the very brief history that you just told me. But, it's more likely that it's driven by eggs that are, like I said, chromosomally abnormal.
And do you feel like the IVF is also, because I like the upstream of my friends, my family members that are having to go through IVF, same thing with Whitney. Whereas, just I feel like a decade ago, no one was really talking about it.
Oh,
and
absolutely.
So is it just because we're hearing more about it, or is it truly because like people are not able to get pregnant anymore? Because I just feel like within the decade, this whole IVF boom has really happened.
That's such a great question.
Yeah.
And I will tell you, it's not that it's changed, right? About 1 in 6 couples is typically found to require medical intervention of some kind in order to create family. That hasn't changed.
Okay.
It's really about finally coming out of the closet. It's finally normalizing it, finally being able to talk about miscarriages and struggling to create the family that you've always wanted. And social media that's the positive, right?
Yeah, right.
That is the huge positive of social media.
Well,
we're even sitting here talking about this.
Yeah.
Exactly.
And that science has evolved too.
Yes.
And that things have become probably more accessible, easily accessible and rampant to do than it once was. Like,
I think that IVF, certainly in the last decade, and genetic testing in IVF has definitely improved enormously. But I do think it's more of being able to normalize the conversation and talk about it. That's real, that you're hearing
about
it.
It
was always there. It's just like, and I will tell you, like I said, I've had the pleasure of working in this field for a couple of decades now, and most of our patients, I would say back then their parents didn't even know they were going through IVF, right?
Right.
So therefore, that's why you didn't hear about it, because they weren't even sharing that with the closest members of their family. And now, it's a podcast.
Yes. Well, and now we're in our mid to late 30s where all of our friends in our circle are in that spot where they're either wanting to and it's hard, or they're just starting to try, or we're at that sweet spot of like, is it going to happen or not? Because soon it won't be able to anymore. But what would you say are some of the most common chromosomal abnormalities and genetic mutations?
So the most common chromosome abnormalities that we see is what we call aneuploidy, which is the loss or gain of a chromosome.
Okay.
So in every healthy cell in our bodies, we have 23 pairs of chromosomes. 23 originally came from the egg, and 23 came from the sperm, together making the 23 pairs, or 46. Now, unfortunately, with these aging eggs, we do see that there can be a loss or a gain of a chromosome in an egg. Okay. And this is, unfortunately, very much directed towards the egg. Now, the sperm has other issues, which is a whole different conversation.
And
well, in regards to genetic abnormalities, right?
Okay. Yeah.
But specifically the egg, and what we typically see in embryos is this loss or gain of chromosomes. Now, if you don't have a whole chromosome, then you're missing all of those genes that are going to be vital for not just embryo development and fetal development, but just to obviously normal function in a adult human, right? So we need all of them, and they have to be that in pairs. And so, that's what we see as the most common abnormality as women age, is these eggs have losses or gains of chromosomes.
Okay. What measures can be taken to help avoid these or screen these? Obviously, we know egg freezing is something to do so that you can have healthy eggs when you go into to make your embryos. But what else can be done if you don't even have that?
Yeah, unfortunately, we can't screen for them, and we don't really need to, because we know we don't need to until the embryo.
Okay.
Basically.
Okay.
So, the best thing that we can do as young women is be proactive and have what we call a fertility assessment, right? It's not going to actually target and screen or test an egg because we can't do that, right? Not
until
non-invasively.
you actually get it extracted.
Correct, yeah. But at least it gives young women that information. I believe information is powerful.
Agreed.
Knowledge is powerful. And so they can get, at that point of time, a readout on what we call their ovarian reserve.
Okay.
And really, even if those young women aren't ready to have a family, just to know what your baseline ovarian reserve is, so that when it comes time that you do want to have a family, then you have a much better idea of are your ovaries aging faster than they should? What is actually happening?
Yeah.
Right.
So that's the best thing that young women can do for themselves.
What age would you recommend?
That's such a great question. We actually did a polling of young women in college. So they were in their early 20s, and they really weren't receptive. And I totally understand. They're at a different place in their lives. So I think that's too young. And I think, mid to late 20s. And like I said, it's a baseline, right?
Right.
It's a baseline for them to have the knowledge of what their ovarian reserve looks like as they head into the rest of their adult reproductive years, right? And it doesn't determine anything, and it doesn't make them have to make decisions or anything like that. It's just knowledge and information for them to go forward.
Right. So it's like a quantity of eggs, right, that you're counting.
So we have, there's an ultrasound of the ovaries in order for us to count what we call the follicles, where the eggs are inside the follicle. Also a blood draw to look at reproductive hormones. And like I said, it's a great place for young women to start. And from there, they have that knowledge and that information, and they can go forward and make decisions, once they obviously at the point where they want to have a family, right?
Totally. Yeah. Totally. So then obviously we know pre-implantation or genetic testing before pre-implantation is important because you're getting all the information that you need to make sure that the embryo is chromosomally normal for the transfer. What are you actually looking for, and how does it benefit the patient to know? Because I know, like I was saying, Timmy he wanted to know maybe which embryo was the strongest, but he didn't really feel the need to know like the grades or who was the second strongest, or he just wanted he felt like he wanted to put the strongest one in and didn't want to think about all the rest to like step in more than we already had. Like, tell me your thoughts on that. Yeah.
You know what's so incredibly fascinating is that every patient and every couple that comes to us sees their journey differently and sees reproductive choices differently.
Yeah.
And that's a perfect case. So many of our patients are like, I want to know everything.
Right.
Everything. You need to tell me everything. I want to talk to you every day.
I'm so not that person.
And that's okay. That's okay.
You're like, I just want the baby. That's all I need to know.
And then there are others, like you just said, who are just like, we trust you. You make the best choices, and we've come to you, and we put our care in your hands, and we're happy with our care, and we want a healthy baby at the end. So, and you get everything in between, basically.
Right.
And so certainly what we love to do is have that conversation of, what is family to you? What do you want to achieve from your infertility journey? And, what can we do with you to get there? And I think that's really important. That there's not one kind of like set that's for every patient that comes through the door, right?
Right.
Yeah.
So the genetic testing.
Yes. So in answer to the genetic testing piece, so that's where we're counting the chromosomes.
Right.
So we actually are able to biopsy or remove a couple of cells from the pre-implantation embryo. And the pre-implantation embryo will have probably around about 100, 120 cells. So we biopsy and remove anywhere between 3 to 6.
Okay.
We don't exactly count. We just take a very small amount.
Okay.
And from that, because every cell has those 23 should have those 23 pairs of chromosomes, we're able to then count the chromosomes. And we do that using a technique called DNA sequencing.
Okay.
And we count the chromosomes. And so that way we're able to identify losses and gains. And why is that important? Because the only way to have healthy fetal development is to have 23 pairs of chromosomes.
Right. But if you're only taking that small portion of the embryo and testing that small portion, That I'm assuming that small portion isn't representation of the whole embryo. So it
So
doesn't.
98% of the time it is.
Okay.
You are absolutely correct.
Okay.
There is what we call mosaicism, where some cells can be chromosomally normal and some cells can be chromosomally abnormal.
Right.
And we see that certainly at CCRM 2.7% of the time. Okay. So, and in clinical pregnancy, we see that between 1 to 2% of the time. So if you look at prenatal testing, so amniocentesis, which occurs in pregnancy.
Yeah.
Mosaicism will be about 1%
Of the pregnancies.
that are tested. At the chorionic villus sampling, which is also a prenatal test that happens a little bit earlier, so the late end of the first trimester, they see even up sometimes some publications have actually reported 1 to 2%.
Okay.
So this is a phenomena that we see in human reproduction, but it really biologically only represents that, as I said to you, on the prenatal side, so amniocentesis 1%, the chorionic villus a little bit earlier in pregnancy, so we see a little bit higher, and then pre-implantation, because we're seeing it right at the beginning of life, we see that 2.7% at CCRM.
Okay.
So, and then the rest of the embryos, going to what you say, are uniform.
Right.
So what the samples, the cells that you test are exactly the same as the rest of the embryo.
It's crazy to hear this breakdown because you just think getting pregnant is so easy.
I
You're
know.
just like, let's have sex and we're going to get
know.
pregnant.
And you spend so much of your life like trying not to get pregnant.
pregnant.
And then,
One of the things that always astonishes me is that reproduction is taken for granted, right?
Yeah.
It is,
It
completely.
is. It's so true.
You can talk to young girls and ask them what their lifetime ambitions are. And not all of them, but a lot of them will say that they want to have a family.
Yeah.
They don't actually say, I hope I can have a family. Or maybe, I will be lucky enough to have a family.
Yeah, right.
They actually say,
We all believe that
I will have a family.
That we just have the choice.
Exactly.
Yeah.
And then, like you said, we spend so many years in our young adult life working with contraception.
Right. Right.
Right.
Exactly.
And so there's this take it for granted. It's just going to happen.
It's so true. Can you actually, back up a little bit. Walk me through what the genetic testing actually looks like the process of it and how long it takes. And
Sure. So we biopsy remove those few cells from the embryo. We do that from what's called a blastocyst, which is an embryo that's at day 5 to day 7 of development. Day 0 is actually defined as the day that we collect the eggs and sperm.
Okay.
And so we are able to grow them in culture in the laboratory. And then on day 5, or day 6 or day 7, and that goes back to grading. So I'll come back around to that.
Okay.
And so what we do is we're able to biopsy. We take those 3 to 6 cells, like I said. And those cells are actually what we call trophectoderm cells, which actually will be the cells that become the placenta. So they're not the cells that become the fetus. And we're very, very, targeted in making sure that we only sample cells that will become the placental cells, because we don't want to prevent the fetus from being formed.
Oh, I see.
Yeah. So the pre-fetal cells, which are called the inner cell mass, are inside the embryo. And so we can see that under the microscope. So we want to make sure that those are left alone so that we can obviously maximize the potential of this embryo to establish a pregnancy and obviously a viable fetus. And we only want to take the outside cells that will become the future placenta. So, which has the same DNA as the fetus.
Yeah.
Right?
I had no idea.
Yeah, I know. Most people don't realize that the placenta actually belongs to the embryo.
Yeah.
Yeah,
I
that's
didn't
new
even
news
think
for
about
me.
the placenta having DNA or any of that. Or when I was thinking about the embryologist taking cells from the embryo, I was like, no, don't do that. The placenta makes me feel a little bit better. Yeah.
Nothing's wasted.
Yes. So then we take those cells and we then put them into a very tiny little tube and they go off into the molecular laboratory and we perform DNA sequencing. And then with bioinformatics, we're able to then count those DNA sequences to then determine how many chromosomes we have, right? So we want 23 pairs.
Right.
So,
okay.
and if we see a missing one or an extra one, then we know the embryo is abnormal.
Okay.
Chromosomally abnormal.
All right.
Yeah.
And so if they get to a certain phase by a certain day, then that means that they're like technically stronger, right?
Yeah. So
Explain
going
that
back
process.
to the, yes.
Yeah.
So it's incredible, but even right from the point of fertilization, which is day 1. So we collect the eggs and sperm on day 0, and we do the fertilization on day 0, and then we'll come in to the lab on day 1 to check for fertilization, make sure that obviously the sperm has normally fertilized the egg.
Yeah.
From that, literally from 24 hours after that, every embryo is different. Every embryo is unique. It's unique in the way it divides, how quickly it divides, how slowly it divides, as in cell division. And so by the time we actually get to day 5, you can look at a cohort of embryos and they're all different. They all look different. It's amazing. So we are so unique right from the start of life, which is amazing.
Yeah.
And so what we do see is we see faster developing embryos, we see slower developing embryos. And that's where that one piece of the grading comes in.
Okay.
And so we know that embryos that take longer to develop to that blastocyst stage that I mentioned, that those actually have a lower potential for live birth.
Oh, I see.
Okay.
Right?
So the faster growing ones are better.
Not too fast. It's
okay.
interesting, but the other side is also not something that we think is as viable, right?
So finding a happy medium.
Exactly.
So difficult.
I know.
But I mean,
at every step.
So the grading, a piece of the grading is exactly that. Did the embryo reach the blastocyst stage on day 5, which is the best, if you want to talk about grading, day 6 or day 7. Now, day 7, we have to go back to the uterus, right? Because in order, implantation occurs around about that time.
So implantation has to happen on day 7?
Around about that time.
Okay.
It's not that it's we need to make sure that day 7, either a day 5, day 6, or a day 7 embryo is transferred into the uterus in order for implantation to occur.
I see.
Yeah. So that's the maximum that we will grow them in culture before we'll do an embryo transfer. Or frozen. Absolutely. Absolutely.
Yeah.
Absolutely.
Okay.
Yes.
Got it.
Yes.
Okay.
But that's the time point that we look at cryopreservation as it's a stop, right? We're able to cryopreserve embryos, which is amazing because it means that patients can have families
later on.
Correct.
But is there any downside of freezing? It doesn't harm.
We have not seen that, no.
Okay.
We have not seen that. Obviously, one of the really important pieces of our jobs is to make sure that we're always following up on our pregnancies. And we have to. We report to the CDC all of our outcomes. It's all IVF clinics do that. And we're able to obviously look at all that data and actually be able to analyze it to answer those kind of questions, right? And we do not see negative association with the cryopreservation. And patients are coming back years later and having their second baby or their third baby or however that works. Wonderful. Also for our fertility preservation patients, right?
Yeah.
Whether it's because they choose not to have a family today or, of course, our oncology patients that need to obviously preserve their eggs and sperm and embryos. Yeah.
Are you able to detect like anything besides is it 23 chromosomes?
Pairs of chromosomes,
Besides that, is there any way to detect maybe future disease or anything that could happen while culturing these cells and giving them the option of like, look, this could happen. I just found this in, like, does that happen?
Not yet.
Not yet. Okay.
It will one day.
Yeah.
Okay.
Now, the future of human reproduction, could potentially look like that. We need to learn a lot more about our genome, all the genes on those 23 pairs of chromosomes and how they are associated with disease.
Right.
Before we could ever do that.
Got it.
And we do know a lot. We've learned a lot. It's amazing the advances in reproductive genetics over the last 10 years, but there's still so much more for us to learn.
Totally.
So the diseases that we are actually able to identify are what we call single gene diseases. And those, we only identify that because the family come to us or the patient comes to us knowing already that it's an inherited disease in their family.
Oh, I see.
So what we can do today is be able to identify and screen for known inherited diseases.
Oh,
for
got it.
Okay.
Okay.
Cystic fibrosis, right?
Right.
Or Huntington's disease, or BRCA for breast cancer.
Mm-mm.
When we have a patient or a couple or a family that come to us, we're able to then actually identify and screen out the affected embryos for them.
Oh, wow. Okay.
But that's because we know what we're looking for.
Mm.
We're not able to just blindly look through the 23 pairs of chromosomes and be able to find new disease. We cannot do that.
Okay.
And like I said, human reproduction will eventually look like that. I don't believe in my lifetime, but you know, it all depends on the advances in genetics. And you know, it's amazing what we have discovered in such a few years, and the discoveries to come are going to be incredible.
Yeah.
But you know, right now we offer these families technology that is incredible because they can come to us and they can say, hey, you know what, my mom died of breast cancer in her 40s, and I don't want my children to be inflicted by this, or my grandchildren, or my great-grandchildren. And that's what we can do. You know, we're able to then sit down with this patient or couple and actually do family planning so that we select embryos that are free of the family mutation.
Oh, wow.
And then the child is born without it.
Mm-hmm.
That's incredible.
That's really
and
amazing.
so we get to literally eliminate that mutation from the family forever.
I mean,
wow.
that's a big thing.
I know.
It's very powerful.
It is
Sometimes you think about
amazing.
this and you're like, for me, you know, being personally into it, I'm like, how much am I messing with, you know, the way that it's supposed to be, you know, and even choosing girls, having the power to choose girls versus boys. I'm like, sometimes I don't like the idea of having a say in this, you know, just want everything to like happen naturally. But I feel like when it comes to that sounds really amazing. You don't have to do genetic testing when you make embryos, right?
No, it is
so you
an
have that
add-on
option.
voluntary procedure that you can select during an IVF cycle. Obviously, you have to do IVF. You have to create embryos in order for us to.
People choose to do it?
You know, we really do target patients that are indicated for it. So, in other words, obviously, women who are what we call advanced maternal age, which is just a nice way to say that unfortunately their ovaries have gotten old. So they're obviously indicated because we know that's the highest risk factor. You know, and then of course there's, you know, patients who have had repeated miscarriages,
right?
Especially if they have been tested from their DNC to show that there is a chromosome abnormality.
Yeah.
There are patients that, you know, that have what we call structural rearrangements where bits of chromosomes have come off and gone onto the wrong chromosome. I mean, there's all sorts of things that we're able to test for. And so there's indications. So it's not something that's just everybody do it. It's very much indicated for patient population.
And would you say most people end up choosing the strongest embryo to implant, or how does that even really get decided? Because it feels confusing with the grading versus your opinion with what you want, and maybe the doctor has a different opinion. So how does that all go down?
Yeah, I mean, in the end, it's the patient's choice.
Of course.
The patient, they're your embryos, they're your body.
Yeah.
It's your choice. So, I mean, that conversation is very much, okay, so we know that this group of embryos are chromosomally normal. So they're obviously the ones that we're going to, you know, talk about in regards to grading. And then we look at the grading and we say this is the strongest based on our live birth data over all of these years. And then we rank them, like you said, you know. And then and we talk about, you know, what live birth rates we can anticipate with each of the individual embryos. And also, if you want to know embryo sex, and that's really the choice of the patient, that's completely your choice.
Right.
If you want to know, you can. And all of that information then becomes your informed decision. So it's really never a recommendation in regards to, you know, the physician saying that you should have this one.
Of course not. It has
it's
to be
very much coming from you. Now, are we going to, as the medical, you know, practitioner, is always going to advocate for hopefully
the best, best, quickest,
exactly.
fastest, healthiest. Yeah.
The highest probability of you
success. Yeah.
of you having a healthy baby.
Right.
And
Right.
that's the conversation.
Mhm.
This embryo here has the highest probability of resulting in a healthy baby.
Mhm.
So obviously, as a medical practitioner, we're going to obviously recommend that one.
Yeah.
Right. That
But
makes
really, it's all about the informed decision from the patient
sense. Mhm.
and what your reproductive journey is and your reproductive choices.
Mhm.
How many times can you do this? It like, let's say it doesn't work out the first time, like, and you might be familiar with this answer,
Mhm. Mhm.
but like, how many times is it safe to do it? Is there a number or is there a limit?
To do like the egg retrieval and
Yeah.
then and make the
Yeah.
embryos. I mean, I've only done it once. Luckily for me, they took out 21 eggs and then they fertilized them and then we were able to make 5 embryos. But it's very dependent on how many they get each time. But I've known people that have done like 10 to 20 cycles of it.
Oh,
like,
wow.
And it's intense. But like, more. Is there a
that-
max even?
Well, I mean, there's no way for anyone to have a max because, I mean, there are circumstances where patients will go to different states or different clinics, and of course, there's no,
Limit.
It's not possible to track all of that. So,
yeah.
It breaks my heart that anyone goes through 10 to 20 cycles. To be honest with you, that just breaks my heart.
Mhm.
I think it's so important in, patients choosing where they're going to have IVF.
Of course.
Is to choose somewhere where you're not going to cycle 10 to 20 times in order to have a baby, right?
Mhm.
And so that, comes around to how important it is. And the CDC publish all the success rates. So it's very easy for consumers/patients, as to be able to look at that and to choose a clinic that obviously will result in success in many fewer cycles than 10 to 20.
Right.
Basically.
I know.
Right?
Yeah. And can there be human error when it comes to this kind of stuff in genetic testing? Like, I know the lab is so important where you go, but is it about the science or is it about the doctors or what makes a lab, like your lab being so amazing, what makes it different than all the other ones? Not all the other ones, but you know what I'm saying?
So I always tell people that it's a team sport.
Yeah.
Okay? It's a completely team sport.
Yeah.
I can promise you, every step is just as important. Obviously, I'm the geeky geneticist, so I'm going to tell you that obviously a genetic testing is critical because we need to be able to make sure when we identify a chromosomally normal embryo that it truly is chromosomally normal as to the best of our abilities. No one is perfect. No one is 100% ever.
Yeah.
No one can give anything in medical or science
we're
a guarantee.
All searching for that.
We wish.
Like
it's not that I don't want to
every
offer
step
it.
of the way. Timmy's always like, well, what are the odds? What odds do you give us? It's like we're always searching for that, like, the answer, but they're just
because I'm sure at some point, let's say like the people that that had to go through it so many times, I'm sure they're questioning like, wait, is it me or is it the doctor or is it, the lab? Like
so many different
there's so many different variables.
Yeah. I mean, even with our last 2 miscarriages, like our surrogate, there was like a bleed involved. And so and those can be totally fine and they cannot be fine.
Right.
So you don't know, was it that or was it, so it's, there's so much unknown.
So what's like the top things that people should look for in a lab? Because obviously there are so many choices out there.
Sure.
So what would you say like the top, I don't know, let's say 3 things?
I mean, obviously success rates, which I was saying, like they're obviously available and transparent. They're so important. I think your connection to your physician is super important. That relationship of trust needs to be there, right?
Yeah.
And, for whatever reason, if it's not, that's going to be a detriment to your care. So that is really important. And then, you can ask those extra things. Like you asked me the question of, why do I think the labs at CCRM are state of the art.
Yes.
And they are state of the art because we add all of those extra quality measures on top of everything to make sure that we are creating the best quality embryos and we are giving the best quality genetic testing. And it's those layers of quality that we have that we ensure are checked off all the time that really deliver the results that we see and the success that we see for our patients. So, and you can ask those questions, to the physician that, or to the clinic or the lab where you're obviously having that first new patient consult. You can ask all those questions. And if you feel like you've been given transparent, honest answers and you have a great rapport with that physician, then you go to home, right?
Right.
You go to home.
It is so important because you're talking about something so personal.
Absolutely.
It's not just science here.
No. And how long the journey is, right? It's not like you're in and out in a week, bye-bye. Don't we all wish, right?
And the way that the doctor deals with things too and their bedside manner and how they talk to you and that was very important to me, the sensitivity and the patience and the willingness to answer questions, all those things we should be made to feel like more than just numbers.
Yeah.
And it seems to me like all the amazing doctors that I've been able to talk to from CCRM have been just so awesome.
And that's one of the things that I am so privileged to work there. And I do. I feel privileged every day when I go to work because I work with amazing people. And I said to you, it is a team sport, but those physicians are just amazing.
Yeah.
Their education, their bedside manner, their empathy, everything.
I mean, you're changing lives here.
Absolutely.
This is something that could make or break someone's life.
Right.
Yeah.
And I want to tell you, because you don't see behind the doors, but every single embryologist and every single scientist that works in genetic testing lab feels the same. We all feel the same. We're behind the scenes.
Yeah.
Totally.
But, we are
really
so dedicated and
Mm-hmm.
focused and really, for us, we love it when we get the letters from patients that send in with their baby photos.
Yeah, you
oh
need
my
to
God.
have the
We
wall
do,
of
I do.
before and
We
after.
do. We do. We
the
have
little embryo with the
we do. We have not a wall with the embryo with the baby, but we definitely have a wall of our babies.
With a picture of the baby next to it.
That can be,
funny.
that's a great baby announcement, right?
Yeah, exactly.
But we have a wall and
that's cute.
So.
And one quick question that's maybe not so fun, and maybe you don't even know the answer, but do you know how much it costs to do the genetic testing?
So, every genetics lab, now we're talking genetics lab, will have obviously their own costs.
Okay.
But, I can tell you that there have been publications that have shown that the cost, and it is a cost, we're all aware of that.
Right.
But the cost definitely outweighs, the benefit obviously outweighs the cost. Sorry.
Right.
That's the better way to put it. Because if you think of failures, you think of miscarriages, all of those are going to occur if it's a chromosomally abnormal embryo.
Right.
Yeah.
And so when you then weigh up all the costs of, multiple cycles from multiple failures, and obviously all the emotional and psychological trauma, the testing definitely is so beneficial.
Yeah.
So beneficial.
Yeah.
Because it's, the fastest path to the healthiest baby.
It makes so much sense.
Yeah.
Well, thank you so much for coming. I appreciate it so much and for allowing me the space to be vulnerable and to really get into it, because even me going through this, there's so much still to learn. And I do think that information is empowering. We need to know when it comes to this. So thank you both for being here.
Thank you.
Thank
you
you
for having me.
Thank you for having me too. And thank you to you both.